Assalamu alaikum and very good morning, everyone. It gives me immense pleasure to invite you to the first free paper sessions of the 19th Shaukat Khanum Cancer Symposium. In this free paper sessions, we have 12 speakers. There would be 12 presentations. Each speaker would present for 88 minutes, and there would be 2 minutes for question and answer sessions. So I would request all presenters to please ensure to finish in time. So our first presenter is Miss Laiba Shah from SKCS University. She will talk about designing anti-MIRS for head and neck squamous cell carcinoma, a network-based approach. So over to Ms. Laiba Shah, please.
Assalamu alaikum and good morning, everyone. I'm Laiba Shah, a thesis student of MS Biotechnology from SKCS University, Peshawar. And currently, I'm doing my final year project at Precision Medicine Lab. My project is mainly about designing anti-miRNAs for head and neck squamous cell carcinoma, and it is a network-based approach. So, before going into further detail, I would like to tell you a little bit about what RNAs are. So, in our genome, we have two main types of RNAs, the coding ones, which are, you must be familiar of one of those, which are the messenger RNAs, and the non-coding one, which have other classes, subclasses of RNAs, like small non-coding RNAs, long non-coding RNAs. And my topic is mainly revolving around a subclass of small non-coding RNAs, which are the miRNAs or microRNAs. So, what are the microRNAs? MicroRNAs are a small 20 to 25 nucleotide in length, and they are distributed in several classification of organisms, as you can see here. And how they generated, so they have their gene in the intergenic or intronic regions of the genome, and then they get transcribed, and going through several processes, they get matured, and they go and bind with the messenger RNA to either degrade that messenger RNA or to translate the repressional mechanism. And by this way, they have a remarkable role in control of gene expression. These are the two scientists who have discovered the microRNAs for the very first time. So let's go through some breakthroughs in history of miRNAs. So first discovered miRNA was in 1993 by these scientists in C. elegans, a worm. Then in human, it was discovered in 2000. First cancer discovered miRNA was in 2002, and then when it went into the clinical trial, it was in 2013. My study approach is basically to solve a problem by enlisting all the head and neck squamous cell carcinoma miRNAs, and then looking for the potential candidate out of those to design some targeted therapy or diagnostic approach for them. So I will be discussing all of these steps one by one. I've started. Okay, first of all, as you all know that it's a network-based approach, so I would like to tell a little about a network. So network is the physical pattern of interaction between two or more than two objects. So it mainly consists of the nodes and the edges. Nodes are basically the objects or entities, while the edges are the link established between those nodes. And my problem was basically this. This is a huge network of microRNAs and genes. The purple dots represent the microRNAs, while the pink dots represent the genes interacting with those microRNAs. So as you can see here, this network contained 8,419 nodes, while more than 18,000 edges. It's just to find a needle in a haystack. I constructed a network of only 64 gene miRNAs, which were associated with HNSCC or head and neck squamous cell carcinoma, and they had 8,354 genes interacting with them. Then what I did was I just filtered out those genes which were mainly involved in HNSCC or head and neck squamous cell carcinoma, and I looked for their interacting miRNAs. So I got 20 miRNAs and 53 genes only. So I created another network called the 2053 network. After that, I put another filter, and I chose the top 8 miRNAs out of those 20 based on the high number of interactors they had inside the cell. So I got 8 miRNAs interacting with 212 genes. Then 8 is still a huge number. We can't design some targeted therapy against 8 miRNAs at the same time, as well as we can't check their expression So I again applied a filter based on high degree value. Every node have its own degree value in a network. So the top degree value miRNAs were chosen, and 5 of those were at the top. So I chose 5 miRNAs and I constructed another network of those 5 miRNAs, and I got 181 gene interactor of those miRNAs, which were potentially involved in head and neck squamous cell carcinoma. So then I perform functional analysis of all the genes to look for where they reside, what biological process they perform, and what are their molecular functions. So the pink bar represent their cellular components. So as you can see, they are mainly present in the cytoplasm and the nucleus, means that they are easy to target and easy to analyze. After that, the purple represents the biological process what they are going to perform. So they are mainly involved in the regulatory processes, means that in cancer they had a potential role. The yellow represent the molecular functions they had. So as you can see, most of them are involved in the binding functions, means that they could have some potential role in cancer progression or in head and neck squamous cell carcinoma. After that, I analyze them for their pathways, that in which pathways they are potentially involved. So I have found by this analysis that they are mainly involved in pathways in cancer. The longest bar you can see over here, or the microRNAs in cancer, means that they are reported also in other types of cancer for their significant values. After this, I also performed some expression profiles or R candidates, which were those 5 miRNAs in other 31 different subtypes of carcinomas based on their log2 expression value. And I got the data from one of the database, OncoMIR, and I got the I've done the analysis and find this statistical review, which you can see over here. After that, I found that 3 of my candidate genes were downregulated and 2 of them were upregulated. You can see the sequence of them over here. To design anti-mRNA against them, it might be needed. Current status of my project is designing anti-MIR and and then checking them on the primary OSTC cell line, which is established for the first time in Pakistan at Precision Medicine Lab. And on this, I would like to conclude my presentation, and I would like to thank my team, Precision Medicine Lab, obviously my PI, Dr. Faisal, and Shaukat Khanum for giving me the opportunity to present my work over here. Thank you so much.
Thank you very much, Ms. Laiba. Excellent work. That was a very interesting talk. Let me just tell that there are 2 judges for this to assess this session. With me is Dr. Kashif Siddiq. So he's a consultant radiologist, and I'm Dr. Muhammad Usman Rashid, working as a senior research scientist at Shaukat Khanum. So our next speaker is Ms. Asma Tayyib from University of the Punjab. She will also talk about microRNAs mediated expression regulation of FASN pathway in acquired chemotherapeutic resistance. Over to Ms. Asma Tayyib, please. If there is any question for Ms. Laiba Shah in the meanwhile, so we can take at least one question.
Yeah, I'm open for question as well as for feedback.
I think there is no question. So thank you very much, Ms. Laiba. So the next speaker is Ms. Asma Tayyib from University of Punjab. Over to Ms. Asma Tayyib, please. We'll move on to the next speaker. We can have Ms. Asma at the end. So let's move on to the next speaker, who is Mr. Rashid Bhatti. He will talk about in vitro determination of anti-cancer activity of medicinal plants against HEPG2 liver cancer cell line. Over to Mr. Rashid Bhatti, please. So in the meanwhile, so our presenter is settling down, so we can move on to the previous speaker. If there is any question for Ms. Laiba Shah, who has presented about anti-MIRS for head and neck squamous cell carcinoma. Okay, so we'll move on to the next speaker. Our next presenter is Ms. Ifat Aleem from Shaukat Khanum Memorial Cancer Hospital. She will talk about Keratin 85 expression in tongue squamous cell carcinoma. Over to Ms. Ifat Aleem, please.
Thank you so much for inviting me. Thank you so much for giving me an opportunity to talk. My study title is Keratin 85 expression in tongue squamous cell carcinoma. Lip and oral cavity cancers are the third most common cancer type seen at Shaukat Khanum Memorial Cancer Hospital and Research Center during the 25 years. And this includes the more than 2,000 patients with tongue cancer. So therefore, tissue-specific stratified tumor markers are needed to aid in accurate diagnosis, determine prognosis, and monitor treatment. Many studies have evaluated keratins as a cancer marker. These are used for cancer diagnosis. Keratins correlate with epithelial mesenchymal transition and cancer stem cell formation. Since K85 is a high burden protein, its expression in tongue tumors can be of therapeutic significance. This study has been carried out with the collaboration of Shaukat Khanum Memorial Cancer Hospital and Research University of Bradford from UK. And this is approved by IRB. The patients were consented and there was no conflict of interest among the co-investigator. Our study is about the disease progression for a single anatomically specific oral cancer trunk from Asian population. In our previous study, there was upregulation in keratin type 2 cuticular HB5 seen in hyperplastic tissue and neck node negative tongue tumor tissue, but remained unchanged in neck node positive relative to non-cancer tissue. There was no reported association of K85 with tongue cancer. However, there was association between the missense mutation in the KRT85 gene with the dysplasia of hair and nail type. There are two types of isoforms of keratin. We studied with the molecular weight 56 kilodalton. The highlighted sequence represent the amino acids to which our Western blotting antibody binds. The aim of this prospective study was to detect protein expression of K85 associated with advancement of tongue squamous cell carcinoma. Total 24 patients were enrolled from 2019 to 2020 at Shaukat Khanum Memorial Cancer Hospital. 48 fresh tissues were collected, in which the number of tumor tissue was 24, with matched normal tissue 24, which was 1 centimeter away from tumor. The inclusion criteria for tongue cancer patient was the adult patients with no known personal history of HIV, HBV, HCV, and no, without status addiction and non-addiction, and with the stage 1, 2, 3, 4, without previous anti-cancer therapy. This is the method summary. We collected samples from the patients and we performed the cell lysis. We measured the protein amount and then we performed the chemistry staining for protein detection. And for protein expression, we performed the Western blotting. And then we cast the gel and we transferred the proteins on the membrane and we treated it with primary and secondary conjugated antibody, which released the detection signal. We add the ECL prime reagent to the blot. It fluorescent the bands, which can be calculated by the GBox gene tool analysis. Normal or neoplastic cells in H&E stains specimen confirmed by 2 histopathologists. Global proteins were extracted by chemical and mechanical force to shear the cells. We performed the Bradford assay for protein quantification, and chemistry staining was performed for protein detection and to see the equal loading of protein. This graph shows the concentration of protein in each sample. Western blotting was performed for the quantification of K85 expression. The image showed the results of representative patients, and we done the images analysis through the gene tool software, and we create the bar chart which shows the variation in KART85 in different stages. As you can see, in non-malignant patient, the expression of KRT85 was downregulated in tumor as compared to normal, but the stage 1, stage 2, stage 3 patients, the tumor shows the upregulated expression of KRT85 as compared to normal. The global expression of KRT85 was detected both in primary normal and tumor tissues. There was upregulation of protein level in both tissues, suggesting it could be a marker of pre-neoplastic changes. So our study provides an insight into tongue-specific cancer progression at molecular level in order to identify keratin 85 as a unique stratified disease marker. As you can see the previous in a bar chart, we can use this marker as a stratified disease marker because it varies in different stages. Complete keratin profile with low and high molecular weight can reduce the false negative cancer diagnosis. Tongue cancer keratin profiling can play a role in diagnosis and prognosis. Further validation is required to confirm whether K85 has a role in tongue tumor formation. And we thanks to the study team at Shaukat Khanum Cancer Hospital and University of Bradford. Saira Slim, she is the principal investigator. Mohammad Zishan, research associate. Asim Farouk is a research coordinator. The Dr. Raza Hussain is a surgeon. Dr. Asif Raya is histopathologist, consultant pathologist. Mr. Muhammad Haseen is from pathology department. Dr. Maheen Maroof and Dr. Madiha Saeed are the pathologist resident, and special thanks to Chris Ritton from University of Bradford. We thank Shaukat Khan Memorial Cancer Hospital to fund this research.
Thank
And
you,
we
Ifat. Thank you for your presentation. That was really
you.
interesting. So we can have time for one question. If there is any question, please. So Ifat, I have a question. So what are the likely benefits of keratin 85 expression detection in squamous
Actually,
tumor?
keratins are used for prognosis and diagnosis. So K85 can be stratified disease marker specifically to stage because it increasing according to the stage. We see the samples, the rest of samples, we see the same expression. So we can keratin 85 use as a stratified disease marker for prognosis and diagnosis too.
Thank you. So our next presenter is Dr. Madiha Sayed from Shaukat Khanum Memorial Cancer Hospital and Research Center. She will talk about prognostic significance of percentage necrosis in clear cell renal cell carcinoma. Over to Dr. Madiha Sayed, please. Dr. Madiha. Okay, in the meanwhile, we have one question, Ifat, one more. So what is your way forward with the current results? I think there is a network problem. So we have one more question for Ifat, if she could answer. So what is your way forward with the current results? So this is a question by Shagufta Ahmed. Okay, we have now Dr. Madiha Sayed. So please start your presentation. Thank you.
Good morning, everyone. I am Dr. Madiha Sayed, Resident Doctor Histopathology at Shaukat Khanum Memorial Cancer Hospital, Lahore. The topic of my presentation is Prognostic Significance of Percentage Necrosis in Clear Cell Renal Cell Carcinomas. Clear cell renal cell carcinoma is the commonest renal cancer, accounting for 65 to 70% of all renal tumors. The tumor commonly affects the adults with average age of 55 to 60 years and with a male predominance. This tumor morphotype in particular is associated with poor prognosis, high rates of local recurrence, and distant metastasis. The prognostic indicators which determine the outcome of the tumor are tumor stage, tumor grade, tumor necrosis, and sarcomatoid and rhabdoid features. Amongst all these prognostic indicators, tumor necrosis is the study of interest and has been investigated by a number of studies with conflicting results. Some studies support the role of necrosis in adverse tumor prognosis, and other studies show contradictory results. So a study performed by Jennifer and Epstein, published in Human Pathology Journal in the year 2017, it states that in the setting of low-grade renal cell carcinomas, extensive necrosis does not have an adverse prognosis. In another study performed by Julin and Brett and published in the Histopathology Journal in the year 2019, it states that tumor necrosis is an important prognostic factor of clear cell renal cell carcinomas, and it is associated with adverse outcome. So the aim of our study was to explore the significance of tumor necrosis on metastasis-free survival in clear cell renal cell carcinomas. We performed a retrospective study with a sample size of 47 cases. All the in-house cases of clear cell renal cell carcinomas were retrieved through hospital archives, for which the follow-up data was available, and the study was performed from year 2014 to 2015. All the in-house cases with upfront radical and partial nephrectomies were included in the study. Also, the tumors with stage 1, stage 2, and grade 1, 2, and 3 were included in the study. We excluded all the incisional biopsies and true-cut biopsies. Also, the cases with family history of clear cell renal cell carcinoma, prior arterial embolization, metastatic disease at presentation, and post-neoadjuvant chemotherapy were excluded from the study. We defined tumor necrosis as microscopic coagulative tumor cell necrosis characterized by well-demarcated areas of necrosis within the tumor. These comprised of dead and degenerating tumor cells, the tumor ghost cells, and the areas of granular, nuclear, and cytoplasmic apoptotic debris. This is what actually we consider tumor necrosis. The extent of tumor necrosis was established through histological evaluation of the H&E stains, and we assigned 3 groups: group 1 with 0 to 10% tumor necrosis, group 2 with 11 to 50% tumor necrosis, and group 3 was assigned for cases with greater than 50% tumor necrosis. Tumor staging was done according to AJCC 8th edition guidelines, and tumor grade was assigned according to WHO/ISUP grading system. So this is the tabulated form of all our cases. As we can see, in group 1, there were a total of 38 cases, and 27 out of 38 cases showed tumor necrosis, and 4 cases showed distant metastasis. In group 2, there were total 8 cases. All of them demonstrated tumor necrosis, and 3 out of 8 cases showed distant mets. In group 3, there was only a single case. It showed tumor necrosis, but no distant met was observed in this group 3. In this table, we can see as the percentage of tumor necrosis is increasing, the percentage of metastasis is also increasing accordingly, the sole exception being the group 3. So this is the group 1. Out of 4 cases in group 1, which showed distant metastasis, 2 were assigned stage 1 and 2 were assigned stage 2. Grade 1 was assigned to 1 case, grade 2 was assigned to 2 cases, and only 1 case was graded as WHO-ISUP grade 3. And they showed osseous, pulmonary, and retroperitoneal metastasis after a follow-up of 5 to 6 years. In group 2, out of 3 cases, there was a single case staged as PT1, 2 cases were staged as PT2, and grade 2 was assigned to 2 cases, and there was a single grade 3 tumor, and they showed adrenal, osseous, pulmonary, and soft tissue metastasis after a follow-up of 5 to 6 years. Well, the group 3, it showed very interesting results. There was a single case in group 3, and it was a stage 2 grade 3 tumor, and it shows 71% necrosis, but there was no met observed in this case. At this point, I would like to mention that the mechanism, the pathogenesis of tumor necrosis, which exactly leads to tumor cell necrosis, is unclear. There are 2 hypotheses. One states that tumor necrosis is caused by, observed in aggressive, rapidly proliferating tumors which outstrip their own blood supply and leading to tumor necrosis. And another hypothesis states that tumor necrosis is caused by anti-tumoral immune response. So this anti-tumoral immune response can be one good reason why our group 3 does not show any distant metastasis. And furthermore, tumor necrosis factor alpha behaves in 2 different ways. It acts along 2 different pathways. One pathway leads to cell death causing tumor necrosis, and other pathway is anti-apoptotic, and it helps the tumor cells in proliferating fast. We compared our study results with 2 other studies. Study 1 by Julin performed in 2019, and the study 2 performed in 2012 by Martin. When we compared our results with these 2 studies, the results were comparable. We performed a univariate analysis. We performed independent t-test, and the p-value turned out to be 0.3. There were certain limiting factors in our study, which I would like to mention. The one major limiting factor was that it was a retrospective study, and about 5 to 6 years back, there was less awareness about the significance of necrosis in clear cell renal cell carcinomas, and that is why much less information was available about the macroscopic extent of tumor necrosis, and we relied predominantly on microscopic assessment. Second limiting factor was that viable tumor was sampled more than the necrotic tumor. And third limiting factor is that there was limited data in the group 3. Why we were left with the limited data? Because we, first of all, we selected all the in-house cases only. Secondly, we further shortlisted it to PT1, PT2, and grade 1 to 3 tumors. And thirdly, we want to assess the effect of tumor necrosis in after a follow-up of at least 5 to 6 years. So, based on our study results, we suggest that tumor necrosis is an indicator of poor outcome in clear cell renal cell carcinomas. In the end, I would like to say a special thanks to Dr. Mariam Hamid and Dr. Noreen Akhtar for their help, support, and guidance. Any questions?
Thank you very much, Dr. Madiha. That was a very interesting talk with some clear translational impact. So we can take one question. Is there any question from the participants? Okay, I have one question. So you excluded cases who underwent or who received neoadjuvant chemotherapy. What was the reason for excluding those cases?
Because the cases who had already taken neoadjuvant therapy, it also causes the necrosis, but it is not actually the tumor-associated necrosis we were interested in. It was the chemotherapy effect caused, tumor necrosis was caused by chemotherapy effect, not the tumor-associated necrosis. Our study is based predominantly on tumor-associated necrosis.
Excellent. And what are your future plans? Would you like to include it as a prognostic marker in the routine clinical setup
Well,
while reporting?
definitely we have already started reporting the tumor necrosis, but as I highlighted that it was a limiting factor in our study, that macroscopic extent of tumor necrosis on gross analysis is very, very important, which was lacking in our retrospective study. And we have started doing it. We assess the tumor associated necrosis on gross.
Okay, thank you very much. Okay, our next speaker is
Thank you.
Dr. Alvina Zera from University of Karachi. She will talk about MSPI polymorphism in CYP1A1 and acute lymphoblastic leukemia risk among adults. Over to Ms. Alvina Zera, please.
This is Adina Zahra. Today I will be talking about I will be discussing the world research work that I conducted as a part of my PhD. This work was conducted at KIPG, Dr. A.Q. Khan Institute of Biotechnology and Genetic Engineering, University of Karachi. And it is entitled as MSP1 polymorphism in CYP1A1 and acute lymphoblastic leukemia risk among adults. Acute lymphoblastic leukemia is one rare cancer, and it is more prevalent in children as compared to adults. Therefore, most of the studies, scientific studies, are also focused on childhood ALL patients instead of adults. So this study was particularly designed to focus on the genetic susceptibility in relation to adult ALL patients. Acute lymphoblastic leukemia, as we all understand, that it is characterized by excessive proliferation of lymphoblasts, and the excessive proliferation results in replacement of a number of healthy blood cells, which may include red blood cells, white blood cells, and platelets. It is a multifactorial disease, and the many environmental factors as well as genetic factors are involved in causing susceptibility to acute lymphoblastic leukemia. And some of these factors include high radiation and exposure to high levels of radiation. It can include both prenatal exposures and postnatal exposures, and exposure to hazardous chemicals, which may include chemotherapeutic agents, chemical carcinogens, environmental toxins, and a lot more. Some genetic syndromes also alter susceptibility of acute lymphoblastic leukemia, like Down syndrome and Bloom syndrome and ataxia. And then there are translocations, chromosomal translocations, and genetic variations, which may also alter a person's susceptibility to development of this disease. The hazardous chemicals that I just mentioned, that includes carcinogens, chemotherapeutic agents, environmental toxins, hydrocarbons, and pesticides, they can be collectively called as xenobiotics. By definition, a xenobiotic will be anything that is present in a biological system but is not expected to be present in that system. In human body, these xenobiotics are when taken up by the cell, they require multiple enzyme system for their metabolism. Generally, they are when they are taken up by the cell, they are initially some enzymes come into action and they facilitate hydroxylation of these xenobiotics, and as a result they are converted into some reactive intermediates. Then these reactive intermediates are further conjugated with glutathione and things and some other components, and this, as a result of this conjugation, the resulting conjugate is later on eliminated from the. So there are mainly two phases. The phase one is based on hydroxylation reaction, and the phase two involves enzymes which facilitate conjugation. CYP1A1 is an gene that encodes a cytochrome P450 1A1 enzyme. This enzyme is a part of a phase 1 machinery of xenobiotic metabolism. It is located on chromosome 15, is around 6 kilobases in size with 7 exons and 6 introns. A number of genetic variations have previously been reported in this gene CYP1A1, and this study is focused on one such single nucleotide polymorphism that is located at the nucleotide position 6235, and it is a substitution from thymine to cytosine. And this study is uh, meant to evaluate whether this single nucleotide polymorphism does alter the susceptibility or risk of acute lymphoblastic leukemia in adult ALL patients or not. The work plan basically comprised of four different steps. The first being sample collection. It was followed by DNA isolation, genotyping, and results analysis. For sample collection, collaboration was first established with Jinnah Postgraduate Medical Center. 5 ml of whole blood sample was collected from patients, and the total number of cases was 66, and an equal number of age and gender match controls were incorporated in this study. After collection of sample, DNA was isolated from those blood samples using phenol chloroform method. The isolated DNA was amplified using conventional polymerase chain reaction, and the amplified product was digested using some restriction enzyme with restriction fragment length polymorphism analysis. For confirmation of the results that were obtained from RFLP analysis, DNA sequencing was performed on selected sample, and all the genotyping results were then statistically analyzed using tools like using statistical parameters that are that include chi-square and odds ratio. So this is a gel image of PCR amplification of the region that harbors this single nucleotide polymorphism from thymine to cytosine at nucleotide position 6235, and as it can be seen here, a clear band of a 639 base pair indicates successful amplification of this region. The amplified product of 639 base pair is then digested with MSP1 restriction endonuclease. This digestion is meant actually to so that we can analyze whether in that nucleotide at that nucleotide position whether thymine is present or cytosine. And as a result, the gel image that we expected would be something like this. As a wild type, that is T allele, when it is present in this amplified amplified product, this region does not contain any restriction site for MSP1 restriction enzyme in that case. But so as a result, in case of wild type, that is T genotype, we obtain a single band of 639 base pair on agarose gel. But in case of substitution from thymine to cytosine at nucleotide position 6235, there is a formation of a restriction site for MSP1 enzyme which results in two fragments which are of 392 and 247 base pair respectively. And in case of heterozygous condition, when variant allele is present in heterozygous condition, all the three bands of 639, 392 and 247 base pair are observed respectively. That was a schematic diagram, and this is the real original gel image of RFLP analysis. Here you can see that lane 2, 4, 5, 6 and 8 indicate T genotype, whereas lane 1 indicate homozygous variant allele, that is CC genotype, and lane 3, 7 and 9 indicate TC genotype.
Please conclude your results, Ms. Elvina.
Sequencing was also performed on the same um, samples, and this also confirmed the results that were obtained from RFLP analysis. And all the three type of genotypes were obtained as a result of sequencing analysis. This was the multiple sequence alignment that was performed, and it indicated both the alleles, T and C alleles were present in our samples, both in cases and controls. Hardy-Weinberg equilibrium test was performed to assure that the controls were true representative of our general population, and p-value of greater than 0.05 indicated that they really were they were consistent with Hardy-Weinberg equilibrium. The genotype and allele frequencies of this polymorphism were determined. The variant allele was present in 21% of cases and 22% controls. Then on the basis of these allelic frequencies, the I-square test and odds ratio were determined, and the p-value greater than 0.05 indicated that this polymorphism and the C allele, that is the variant allele in this case, was not associated with acute lymphoblastic leukemia development among adults. In this way, we can conclude this presentation by saying that all the three variant genotypes were observed in both cases and controls in our population. The variant allele was present
Thank
in
you very
21%
much,
cases.
Ms. Elvina. So we'll move on to the next presenter, Ms. Sualia Mustafa. She'll talk about the role of GA68 PSMA PET CT in staging of prostate cancer. She is from SIUT, Karachi. Over to Ms. Saleha Mustafa, please.
Assalamualaikum. So this is Swaliha Mustafa, nuclear medicine technologist at Sindh Institute of Urology and Transplantation. And today I'm going to be presenting my study, and the topic of the study is the role of gallium-68 PSMA PET-CT in staging of prostate cancer and correlating it with the histopathology. So PSMA stands for prostate-specific membrane antigen, and it is normally expressed on the prostate gland and the surface on the membrane of the prostate gland. So when there is a malignancy, when there is a tumor, so this expression increases up to 100-fold. So what we do for a PET-CT scan is that we take the generator eluted gallium-68 radioisotope, and we label it with the PSMA-11, which is a complex structural chemical, and then they bind together, and then we inject this radiopharmaceutical into the patient's body according to its weight. And then what happens inside the body is that this gallium-68 PSMA-11 goes to the PSMA that is present on the surface of prostate gland, and then this is a very highly tumor specific diagnostic test that we have. How do we quantify our test? Is we use the SUV, standard uptake value, and it tells us that how much of this radiopharmaceutical is uptaken by the patient's body. So this is a structure of gallium-68 PSMA-11, and as we can see, this blue part, this is what is responsible, and this
Excuse
goes.
me, Ms. Swalia, may I request you to please also move your slides because we can't see the next slide. Could you please move on your slides as well?
I have already moved my
Okay.
slide. I'm on the third slide actually.
Okay, thank you.
Okay. So this blue part, can you see it now? Okay, so this blue part is what goes on to the PSMA that is present on the membrane, and it binds to the PSMA present on the prostate gland. So objective of our study was to evaluate the role of gallium-68 PET-CT in the staging of prostate cancer and to correlate it with the histopathological grade that we are getting, and to also determine the incidence of nodal and distant metastasis respective of the Gleason score of patients. So we took the data of 119 patients, which were scanned at our department from January 2019 to September 2020. And then we classified the patients into 5 groups according to their Gleason score. So in group 1, we placed the patient that has the Gleason score of 3 plus 3. In group 2, we placed a patient 3 plus 4. In group 3, 4 plus 3. And in group 4, 4 plus 4. And in the last group, we placed the patient that had the grade 9 and 10 prostate cancer, which includes the Gleason score of 4 plus 5, 5 plus 4, and 5 plus 5. And what we did then that we compared the histopathological data with what we're getting from our the data that we got from the gallium-68 PSMA 11. We compared the SUV max. We calculated the mean SUV max in each group, and we also found out the incidence of nodal and distant metastasis. And
I'm afraid एक तो यह कि आपकी presentation full slide presentation mode में नहीं और slides move नहीं हो रही, so we have to stop it. We'll move on to the next presenter. She is Dr. Sara Rahman. She will talk about sonographic evaluation of incidental synchronous masses in non-breast cancer patients, clinical significance and diagnostic workup. Dr. Sara Rahman from SKMCH. Over to
Assalamu alaikum. I'm Dr. Sara Rahman. I'm working as senior instructor in radiology department, Shaukat Khanum Hospital. Today I'm going to talk about sonographic evaluation of synchronous masses in known breast cancer patients, clinical significance and diagnostic workup. The purpose of this study was to determine the diagnostic accuracy of breast ultrasound in classifying incidental synchronous breast masses as benign or malignant, and to assess the impact of these findings on surgical management of these patients. Breast ultrasound is a useful technique in evaluation of breast lump because it is cheap, easily available, and precisely categorizes breast masses as benign or malignant. And at the same time, it guides interventional procedures like ultrasound-guided biopsy, FNA, and clip placement. Multifocal multicentric breast cancers are 2 or more discrete synchronous tumors within the same breast. We call them multifocal if they are in the same quadrant with less than 5 centimeters of interlesional distance. And it is termed multicentric when they are in opposite quadrant with more than 5 centimeters of interlesional distance. Synchronous tumors have an incidence of 4 to 65% of all breast carcinomas. And this variability is due to differences in synchronicity definition and the pathological variability in sampling of breast specimens. While the annual incidence of contralateral breast cancer is from 0.3 to 3%. The diagnosis of multiple tumors greatly influences the management plan, especially the choice of surgery. So pathological evaluation of satellite masses should always be done. This is a retrospective study in which the imaging and pathology of breast cancer patients coming to Women's Imaging Department of Shaukat Khanum Hospital were reviewed from 1st January 2017 to 31st December 2018. A total of 225 patients were included, and data analysis were done on SPSS version 25. Online EpiTool software were used to compute the sensitivity, specificity, and positive negative predictive values. We included all breast cancer patients with more than one mass on ultrasound for which histopathological diagnosis was available. While breast cancer patients with unifocal disease or those with satellite masses for which pathological diagnosis was not available were excluded. Ultrasound features which were looked for the satellite masses were margin, shape, orientation, echo pattern, and vascularity. And the descriptors were according to ACR Byred Atlas 5th edition. Masses with circumscribed margins were categorized as benign, while not circumscribed margins, which included irregular, speculated, ill-defined, and microlobulated, were termed as malignant. Oval and parallel masses were categorized as benign, while not parallel orientation was taken as malignant. All malignant masses have hyperechoic echo pattern, while benign can have hyperechoic, isoechoic, or mildly hyperechoic. Presence of increased vascularity was taken as a malignant feature. In addition to these features, we also documented the total number of satellite masses, their clock orientation, and distance from the main mass. And on the basis of this, they were categorized as ipsilateral and contralateral, and the ipsilateral masses were further subdivided into same quadrant and opposite quadrant. In addition, the histopathology of satellite mass and type of surgery performed were also documented. These are images from one of the patient in which figure A shows the main malignant mass in the right breast upper inner quadrant 1 o'clock, which is IDC grade 3. This is a satellite mass at 1 o'clock, which is irregular, hypoechoic, and it sonographically classified as malignant, and it turned out IDC grade 2. This is as another satellite mass at 10 o'clock, which is parallel, hypoechoic, and circumscribed. It is sonographically classified as benign, and it turned out sclerosing adenosis. So in this case, the histopathology and ultrasound features were concordant, and patient underwent breast conservation treatment. These are images from another patient in which the figure A shows malignant mass in the right breast 5 o'clock. This is a satellite mass in the right breast 10 o'clock, which is speculated and sonographically classified as malignant, and it turned out IDC grade 1. Another satellite mass in the left breast 10 o'clock was irregular with not parallel orientation, sonographically classified as malignant. So again, the histopathology and ultrasound features were concordant, and patient underwent lumpectomy of the right breast mass and wired localized excision for these two satellite masses. Another example in which figure A shows the main malignant mass and figure B shows the couple of satellite masses in the same breast, which was sonographically classified as benign, but they turned out DCIS. And these are the two satellite masses in the contralateral breast, which were sonographically classified as malignant because of irregular outline microlobulated margins, but they turned out benign. So in this case, the histopathology and ultrasound features were discordant, and patient underwent breast conservation treatment for the left breast, while no surgery was done for the contralateral breast. So we evaluated 288 satellite masses in 225 patients. This was because some of the patients had more than one satellite. Most of the patients had one satellite mass, while around 50 patients had two satellite masses, 17 had three, and presence of more than three was taken as multiple. Interestingly, the final histopathology showed equal incidence of benign and malignant masses. This table shows the occurrence of various benign entities. We can see that the larger number of satellite masses were stromal fibrosis or fibroepithelial lesion. In this table, we can see that out of 144 malignant masses, 91 turned out IDC. This bar graph shows the location of synchronous satellite masses. We can see that 88 of the malignant masses were in the same quadrant, while there were 8 masses which were in the contralateral breast. And the benign masses, which are shown by blue color, show almost equal incidence of on the same quadrant, different quadrant, or contralateral breast. Considering the margin of satellite masses, we can see that around 73% of the benign masses showed circumscribed margins, while 1/3 of the malignant masses had indistinct margins. Now, discussing the shape or orientation of the satellite masses, around 87% of the benign masses had a parallel orientation, while equal number of malignant masses had not parallel orientation or parallel orientation. Now talking about the echo pattern of the satellite masses, almost 100% of the malignant masses had hypoechoic echo pattern. 5% of the benign masses were isoechoic, while 95% were hypoechoic. There was no hyperechoic mass in our study because most of the time the hyperechoic masses with well circumscribed margins are lipomas, and they can be confidently categorized as BI-RADS 2, and no biopsy is required. Now talking about the Doppler evaluation, which was not done in most of the satellite masses, while in those in which it was performed, we can see that 11 of the malignant masses had increased vascularity. Only one benign mass showed increased vascularity. So out of the 123 masses which were classified as sonographically benign, only 17 had discordant pathology, while 106 showed benign pathological outcome. Of the 165 masses which were sonographically classified as malignant, 127 showed malignant pathological outcome, while 38 showed benign pathologic. So based on these results, there was a statistically significant association between the sonographic features and pathological outcome, with p-value of 0.007, sensitivity 88, and negative predictive value 86%. So this slide shows the various types of breast surgeries which were offered to the breast cancer patients. We can see that breast conservation surgery was done for a single malignant mass in 61 patients. This category included patients which had malignant satellite masses in which the breast conservation surgery was possible. This included wider excision with the satellite, double lumpectomy, wide localization of the lumpectomy,
Please conclude
and
your results.
quadrantectomy. MRM was done for multifocal disease, as well as this category included 12 patients with unifocal disease, in which the breast conservation was not possible because of small breast size or poor chemotherapy response. 4 patients had breast conservation for the contralateral breast, and bilateral MRM was done for 4 patients. There were earlier studies in which the ultrasound features were evaluated for benign and malignant features, and they were compared with the histopathology, and they had a very high sensitivity specificity of around 98 to 99%. In our study, the results were a bit different because the patient population consisted of only breast cancer patients, and the satellite masses were evaluated instead of the primary presenting mass. So results can be different from the screening population. So our study concludes that ultrasound can accurately classify breast masses as benign or malignant, but at the same time, we should always keep in mind that there are many benign conditions that can mimic the features of malignancy in ultrasound. And similarly, in breast cancer patients, the incidental masses have increased risk of malignancy. So ultrasound-guided biopsy should always be done to choose the most appropriate surgical plan. Thank you.
Thank you very much. We'll move on to the next speaker, Miss Hadia Said from Shaukat Khanum Memorial Cancer Hospital. She'll talk about non-visualization of sentinel nodes on T99M HSA scintigraphy. What does it mean? Over to Miss Hadia Said, please.
Assalamu alaikum. My name is Dr. Hadia. I'm a resident year 2 of nuclear medicine in Shaukat Khanum Hospital. My study is non-visualization of sentinel lymph node on technetium 99 MHSA scintigraphy. And what does it mean? Cancer is very prevalent throughout the world, and in females, breast cancer is the most prevalent cancer. Out of all, this is the top 10 malignancies seen amongst all age group, both genders combined, and breast cancer exceeds them all. In Pakistan, 1 woman out of 9 have all breast cancer in their life, and most common histology of breast cancer is ductal carcinoma, with invasive lobular carcinoma being the second one. The most targeted strategy to treat breast cancer is primarily through surgery, and sentinel lymph node scintigraphy is used for visualization of sentinel lymph node, and it helps in determining that whether the axilla is involved in the tumor and has the cancer metastasized to the axilla, and do we need to perform axillary lymph node dissection. For this purpose, nuclear medicine department, we use a radiopharmaceutical, which is technetium 99M labeled human serum albumin. This is injected subcutaneously to the patient's periareolar skin around activity of around 220 MBQ is injected at 2 points preoperatively. After injecting, the patient is imaged by a gamma camera 40 to 60 minutes afterwards to determine that has the radio tracer traveled to the sentinel node, and have we successful in localizing the sentinel node. If the scan is not clear, a SPECT CT is performed. If the sentinel node is not visualized, then a delayed scan is performed on the morning on the day of the surgery. During surgery, peroperatively, the gamma probe is used for detection of sentinel lymph nodes. The gamma probe is a smaller version of a gamma camera with a collimator attached. It is very sensitive in localizing the sentinel lymph node. The aim of my study was to determine the histopathology of lymph nodes that were not visualized on sentinel lymph node scintigraphy. This was a retrospective study done in Shaukat Khanum Hospital. We use hospital information system to review sentinel scans of patient, and afterwards review their histopathology, which was obtained post-surgery. A total of 2,762 sentinel lymph node scans were done from April 2015 to June 22. Planar imaging was done in all of these patients. In these scans, 55 patients, in 55 of these scans, sentinel lymph node was not visualized initially. In all of these scans, planar imagings were done, and then 31 patients had added SPECT CT. In all of these patients, 55 patients, gamma probe detection was used peroperatively to detect sentinel lymph node. Patent blue dye was also used to augment our search of sentinel lymph node in 27 patients. The results of my study were that the total patients were 55, age was ranging from 22 to 71 years. In 55 of the scans, initially, sentinel lymph node was not visualized on planar imaging. In 39 of these patients, sentinel lymph node was visualized peroperatively via gamma probe during the operation. In 16 patients, even gamma probe was not able to detect a sentinel lymph node peroperatively. In 7 of these, the adjacently used patent blue dye was able to visualize a lymph node. Overall, 45 of the sentinels which were done and their frozen sections were obtained, their histopathology afterwards showed that 25 of these were positive for metastasis and 19 of them were negative for metastasis. In 9 patients whom sentinel lymph node was not visualized on sentinel lymph node imaging as well as by the use of patent blue dye, the whole axilla was dissected. In these patients, post-operatively, histopathology reported that all the axillary lymph nodes were involved in metastasis. This proves that the lymphatic drainage was blocked and hence the radiotracer was unable to transit through it, and it didn't help in identifying the sentinel lymph nodes. Hence, it is proven that the non-visualization of sentinel lymph node on scintigraphic imaging has a positive predictive value for metastatic involvement of the axilla in breast cancer patients.
Please conclude your results.
Okay. And this proves that the sentinel lymph node scintigraphy is very helpful in determining that whether the axillary lymph nodes are involved in cancer or not.
Thank you very much, Dr. Hadia.
Thank you so much.
We'll move on to the next presenter. Is from Mr. Rashid Bhatti from University of the Punjab, Lahore. He will talk about in vitro determination of anti-cancer activity of medicinal plants against HEPG2 liver cancer cell lines. Over to Mr. Rashid Bhatti, please.
Good morning, everyone. I am Dr. Rashid Bhatti from Molecular Biology Department, University of the Punjab, Lahore. I am presenting the work of my MPhil student. The topic of presentation is in vitro determination of anti-cancer activity of medicinal plants against HEPG2 liver cancer cell line.
Please share your slides. We can't see your slides, please. Rashid, we can't see your slides.
Okay.
Please share your presentation in the presentation mode, please. Okay, so we'll move on to the next presenter, who is Miss Tahreem Zafar from Shaukat Khanum Memorial Cancer Hospital and Research Center. She will talk about 68 GA DOTA in neuroendocrine tumors, institutional experience. Over to Miss Tahreem Zafar, please.
Good morning, I'm Dr. Tahreem Zafar, resident in Nuclear Medicine Department, Shaukat Khanum, Lahore. I would like to discuss our study done in SKM on gallium-68 DOTA PET-CT in neuroendocrine tumors. Neuroendocrine tumors have incidence of 35 cases per 1 lakh people in United States, with most common sites in gastrointestinal tract and lungs with expression of somatostatin receptors. And these receptors are used for radionuclide imaging as well as therapy. Imaging has been done for decades by using SPECT-CT, in which indium was used, which used to act on receptor subtypes 3 and 5. But now in this era of PET-CT, gallium-68 has replaced indium, in which DOTA is used as a chelator and bound to the peptide, and its act on the receptor subtype 2. Gallium-68 helps in diagnosing the tumor site, but it also has the physiological distribution, which is the highest intensity occurs in spleen, followed by adrenals, kidneys, and pituitary gland, and moderate uptake occurs in liver, salivary glands, and thyroid gland. The objective of our study is to evaluate the impact of gallium-68 DOTA PET-CT in neuroendocrine tumors. Our study is retrospective, in which PET-CT scans were reviewed between December 2019 to August 2020. 49 number of patients were included, in which females were 22 and males were 27, with the age range of 3 to 75 years. 46 were non-cases of neuroendocrine tumor and 3 were suspicious. Out of 46, 32 scans were at baseline, 13 restaging, response evaluation, 1 for surveillance. On histopath, well-differentiated neuroendocrine tumor comprised of 26, grade 1, 19, with grade 2, 7. Poorly differentiated neuroendocrine tumors were 7, medullary thyroid carcinoma 6, pheochromocytoma 5. Histopathology was not available for 5 patients. The most common system involved by the primary tumor site was GIT 47%, followed by endocrine system, urogenital system 16%, 10% were lung, 5% multi-organ involvement, and 3 systems involved 2%. DOTA added additional information and helped in diagnosing distant metastasis in 44.9% of patients, localized disease in 30.6%, and no DOTA avid lesion was diagnosed in 24.4% of patients as a result of post-surgery. SUV range of primary tumor 3.7 to 73.1 with mean of 18.6. Sensitivity of gallium-68 DOTA is 72.2 to 100% with specificity of 77.8 to 96.1%. Crown A et al. Added an information that initial imaging with gallium-68 DOTA PET-CT revealed additional metastatic disease in 48% of patients, which has a great impact on the management plan. Another publication done in Journal of Nuclear Medicine in 2012 also suggested that patients with suspicion of neuroendocrine tumor on the basis of clinical symptoms and elevated tumor markers chromogramin, gallium-68 PET-CT helps in diagnosing and has high accuracy. This is a case image of 48 years old male with gastric neuroendocrine tumor. As you can see, image A is PET-only MIP image, which shows DOTA avid lesion, which is in the region of pancreaticoduodenal mass and shows that there is no distant metastasis, which is also seen on axial CT and PET-CT fused image. This is another case image of 41 years old female with MEN2A syndrome. In this, the two DOTA avid lesions are seen, one in the right thyroid lobe and another one in the left adrenal gland, which were malignant in nature. The limitations of our study is that it's a retrospective study with a very small number of patients. Hence, to conclude, gallium-68 DOTA peptide is the PET radiotracer of choice for initial staging and follow-up of neuroendocrine tumors. Thank you so much. Any questions?
Thank you very much. Yeah, thank you very much, Dr. Tareen. There is one question from Dr. Sana Gill. So
Yes.
she asked that when is it preferred to get FDG PET? And
FDG
not
PET
about
is
DOTA.
okay. FDG PET is done in poorly differentiated neuroendocrine tumors, but in well-differentiated DOTA, gallium-68 DOTA is preferred because it acts on the receptor subtypes. So histopath is very important.
Thank you very much. And is there any clinical implications for this work?
Yeah, there is clinical implication of this work. That it has a great role in management plan.
Okay. She again asked another question. Do you think DOTA PET-CT will become the first line imaging modality?
Yes, I think it will become a first-line imaging modality very soon, and it depends upon the availability, and you can say like it is really beneficial in diagnosis, and it can change the management plan.
Okay, thank you very much.
Welcome.
Thank you. So we'll move on to the next presenter. She is Dr. Asma Tayyab from University of the Punjab, Lahore, Pakistan. She'll talk about role of microRNA mediated expression regulation of FASN pathway in acquired chemotherapeutic resistance. Over to Ms. Asma Tayyab, please. Okay, in the meanwhile, we'll take another presentation from Dr. Maida Muzaffar, Shaukat Khanum Memorial Cancer Hospital and Research Center. She'll talk about role of 18F FDG PET-CT in the diagnosis and management of plasma cell disorder. Over to Dr. Maida Muzaffar, please.
Good morning. I am Dr. Maida Muzaffar from Nuclear Medicine Department, and I'm going to discuss the role of F18 FDG PET-CT in the diagnosis and management of plasma cell disorders. So plasma cells arise from B cells, and plasma cell disorders are a cytogenetically heterogeneous group of plasma cell proliferative disorder. So they secrete abnormal immunoglobulins that are monoclonal M proteins, and they are heavy chain and light chain restricted immunoglobulins. So the most common type of plasma cell disorder is the multiple myeloma, and it is almost always preceded by a preclinical state which is called monoclonal gammopathy of undetermined significance. Later progresses to into smoldering multiple myeloma and then active multiple myeloma. So the multiple myeloma is the second most common cause of hematological malignancy, and it represents 1.8% of all new cancer cases in the US. These are the stats of cancer stats of the United States. The study at SKM done by our team the objective was to determine the role of F18, FDG, PET-CT in the diagnosis and management of plasma cell disorders. The total number of patients were 45 during a course of almost 11 years from January 2009 to August 2020, and a hospital information system was used to retrospectively drive all the data. The results were male patients were more than the females, and the age range was 23 to 75%. A total of 79 scans were required. The breakup of these scans show that the staging scans were 23%. However, the restaging scans were 58%. So this is the International Myeloma Working Group updated criteria for the diagnosis of multiple myeloma by Raj Kumar in Lancet 2014. This shows that one or more osteolytic lesions on the skeletal radiography, CT or PET-CT. This is now the myeloma defining event as shown in this International Myeloma Working Group updated criteria. So the classification of plasma cell disorders as seen in our study were multiple myeloma, secrety were 44%, and non-secrety multiple myeloma were 18%. The rest of them were either solitary plasmacytoma with or without bone marrow involvement, or there was a suspicion of plasma cell disorder. So the characteristics of the skeletal lesions that were identified on the PET-CT were avid skeletal lesions were 68%, non-avid lytic lesions were 24%, and no lesions were identified in 7% of the cases. Of the hypermetabolic osseous lesions, the SUV range was 2.5 to 23.5. The rest of the metastases that were identified were visceral 20% and nodal in 29% of the cases. Of the staging scans that we saw, 18 of the staging scans, PET-CT was able to identify confirm the initial diagnosis in 78% of the cases by identifying additional osseous metastases in 78%. Thus, it changed the initial management plan in 44% of the patients. Of the restaging scans, PET-CT, FDG PET-CT was successful in identifying the progression of disease in 31% of the patients and partial response in 26%. All the rest were either good response, complete metabolic response, no disease, or inactive lesions. So there were two groups of plasma cell disorders. The first group is the solitary plasmacytoma with or without bone marrow involvement, and the non-secrety multiple myeloma. In this, the PET-CT was able to identify and confirm diagnosis in 93 patients in alter treatment plan and 50%. The second group was secretory multiple myeloma. In this, PET-CT was able to identify additional osseous lesions in 70%. So this is the case one of a 30-year-old female with solitary plasmacytoma. The first image on your left hand is a restaging scan after just chemo, showing by the red arrow is the mediastinal lymphadenopathy, and the blue arrow is the primary lesion in the right femur. This is a head of print in MIRT by Gill SM et al. In the next image on your right hand, there is a regression of mediastinal lymphadenopathy. However, there is identification of additional sites of disease, which was later proved to be radiation-induced osteosarcoma. The second case is a 48-year-old male with sacral plasmacytoma. The first image on your left hand is the staging scan, which shows hypermetabolic activity in the sacral region, which is shown by the red arrow. However, the second images on your right hand show CT only, axial CT only images show morphological presence of disease. However, PET-CT fused images and MIP image PET only show no evidence of disease. So this was a complete metabolic response. So our study was in concordance with the consensus statements of an International Myeloma Working Group, Conway et al. Published in Lancet 2017. They suggested that PET is a valuable option as it distinguishes between metabolically active and the inactive disease by identifying the lytic lesions and extramedullary disease. So they proved that it is the gold standard for evaluating monitoring response to therapy. So this is a slide showing studies of F18, FDG, PET-CT as part of initial workup. As you see this Fonti et al. In 2008 shows PET-CT sensitivity of 97%, but over the course of the years, in Sagar et al. In 2011 shows PET-CT sensitivity to be 90% versus all the conventional modalities, especially chest X-ray and MRI, to be 84%. So the limitations of our study was it was a retrospective study with a small cohort of patients, and plasma cell disorders are a varied spectrum of disease, and it involves many more subtypes of plasma cell disorders. To conclude, F18 FDG PET-CT has a promising role in identification, diagnosis, and management of not only solitary plasmacytoma, but also in multiple myeloma, either secretory or non-secretory, as it identifies additional bone disease in 70% of the cases. So this is a slide showing non-FDG tracers that are under consideration for the management of multiple myeloma. None of these have been proved to be better than F18 FDG PET-CT. So I conclude by saying it again that F18 FDG PET-CT is the tracer of choice for initial workup and management of multiple myeloma. I thank you very much.
Thank you very much, Dr. Maida, for a very interesting presentation with clear clinical benefits. Dr. Namra Asgar has asked, what is the added benefits of FDG PET, specifically in staging and also in restaging patients of plasma cell tumors?
When compared to the conventional imaging, the PET-CT has an additional benefit by telling what is metabolically inactive and what is metabolically active. So by identifying locally what about the active disease, PET-CT will change has proved to change the management plan of these patients as compared to the conventional imaging.
Thank you very much. So we'll move on to the next speaker. Ms. Swaleha Mustafa from SIUT Karachi. She'll talk about the role of gallium-68 PSMA PET-CT in staging of prostate cancer. Over to Ms. Swaleha Mustafa. I hope this time she could share her presentation.
This is Swaleha Mustafa, and I am nuclear medicine technologist at Sindh Institute of Urology and Transplantation. And today I'm talking about my study, role of gallium-68 PSMA PET-CT in staging of prostate cancer and correlating it with the histopathology. So PSMA is a membrane antigen, prostate-specific membrane antigen that is normally expressed on the prostate gland. And when there is a malignancy, the expression increases up to 100 folds. And so what we do for a scan is that we take the radioisotope, which is generated eluted through our generator, gallium-68, and we label it with the PSMA-11, which is a complex structure molecule. And then we inject it into the patient's body according to their weight. And what happens is that this gallium-68 PSMA binds to the PSMA present on the prostate gland. So this is a highly specific, tumor-specific diagnostic test that we have. And how do we quantify our test is through SUV, standard uptake value. So what we do is that we visualize the SUV of every organ, and then we can see how much of gallium-68 PSMA-11 is uptaken by that specific cell. So as you can see, this is a structure of gallium-68 PSMA-11, and this blue part here is responsible for the binding with the membrane antigen present on the prostate gland surface. So the objective of our study was to evaluate the role of gallium-68 PSMA PET-CT in staging of prostate cancer and to determine the incidence of nodal and distant metastasis irrespective of the Gleason score. So we collected the data of 119 patients, which were scanned during January 2019 to the September 2020. And then we classified the data in 5 groups according to their Gleason scores. So in group, we placed the patient that had the Gleason score of 3+3 in their histopathology. And in group 2, we placed the group 3+4. In group 3, we had the patient with 4+3 score. In group 4, we had the patient with 4+4. And in group 5, we placed the patient with grade 9 and 10 prostate cancer, which includes scores of 4+5, 5+4, and 5+5. And then we compared the Gleason scores with the imaging findings. And we calculated the SUV max mean in each group, and we also calculated the incidence of in nodal and distant metastasis. And these are the results that we got. So as you can see, there is almost a linear relationship. As the tumor is getting more and more aggressive, there is an increase in SUV in each group. So we in the least aggressive group 3+3, the SUV is 10.4, which is the mean in the group, and we are moving towards the 4+4 and grade 9 and 10, which are more aggressive tumors. So we can see the SUV is 18.45, and in grade 9 and 10 26.09, which is almost more than half, more than double of what we are seeing in the least aggressive groups. So we use the statistical analysis, and we use the Spearman's rank correlation, and it shows that there we have a strong and positive correlation between the aggressiveness of neoplastic cells and their ability to uptake the amount of gallium-68 PSMA tracer. The R value is positive 0.90. We also calculated the occurrence of nodal and distant metastasis. And as we can see that there in the least aggressive group, the percentages are pretty low. And when we're moving towards the more aggressive groups, we can see a huge and drastic difference in the occurrence of nodal and distant metastasis. We can see that in the 3+4 and 4+3 group, the SUV was not much different, but we can see the difference in the occurrence of the nodal metastasis and between these two groups. And
Ms. Solia, please conclude your results.
okay, so if we compare the TNM staging with Gleason scores, we can see the majority of the groups in the more aggressive group are of T3 and T4, and least aggressive we have T2 and T3. And this is a representative cases of each group. We can see that then in grade 9 and 10, the SUV is 52.26, while in the least group is 7.52. So the drastic difference in the SUV in the aggressive, as the tumor is getting more aggressive, the SUV is getting more and more. And there is a low risk case which is just a organ confined disease, and this is a high risk group, high risk case, which has we can see the metastasis in the 5th rib and suprapubic nodes, and also the involvement in the urinary bladder. So this concludes that gallium-68 PSMA PET-CT highly correlates with the histopathological grade, and it is proven to be a significantly reliable prognostic tool for monitoring and management of the disease. So I would like to thank Institute of Urology and Transplantation for providing me the resources, and Shaukat Khanum Memorial Team for presenting my study.
Thank you very much, Ms. Solia. That was a very interesting clinical study. So we'll move on to the next presenter, who is Dr. Muhammad Saqib, Fellow in Gastroenterology of Shaukat Khanum Memorial Cancer Hospital and Research Center. He will talk about safety and efficacy of hepatitis C virus treatment with sofosbuvir-based direct-acting antivirus in cancer patient. Over to Dr. Saqib, please.
Thank you very much, sir, for giving me the opportunity to deliver my study here on this forum. My name is Dr. Muhammad Saqib. I am the gastroenterology fellow at Shaukat Khanum Memorial Cancer Hospital. The title of my study is Safety and Efficacy of Hepatitis C Treatment with Sofosbuvir-based direct-acting antivirals in cancer patients. So as you know, chronic hepatitis C is very prevalent in our country, and it is associated with increased risk of drug toxicities, cancer-related complications, and overall mortality in cancer patients. There's a paucity of data in literature, and there are also no clear guidelines about the treatment of hepatitis C in patients on active cancer treatment. So the aim of our study was to evaluate the safety and efficacy of direct-acting antivirals in patients on concomitant chemotherapy. So after institutional review board approval, we performed a retrospective cross-sectional review of all the cancer patients treated for hepatitis C using direct-acting oral antivirals from January 2014 to December 2019 at Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore. A total of 88 cancer patients were included in the study, and they were divided into two groups. The first one was the concomitant treatment group, who received antiviral therapy as well as treatment for hepatitis C simultaneously. And the other was direct-acting antiviral group only, in which hepatitis C treatment was given after the completion of cancer treatment anytime in past 6 months. The patient's demographics, which including the age, gender, comorbid condition, type of cancer, HCV genotype, HCV RNA by PCR, CBC, LFT, creatinine, past treatment of hepatitis C, chemotherapy, side effects, drug interaction, and complications were recorded. Sustained viral response, SVR, was defined as undetectable HCV RNA by PCR at 12 weeks after treatment. So let's discuss the results. As regards the baseline characteristic for all study participants, mean age was 42 in concomitant group, while it was 49 on DA only group. Majority of the patients were male in concomitant group, while they were more in the female in the DA only group. Comorbid conditions were 14% in concomitant group, while 25% in the DA only group, and process was present in 35% patients in concomitant group and 40% cases in DA only group. The malignancies which our patient have were further divided into hematological malignancies, non-Hodgkin lymphoma, acute and chronic leukemia, multiple myeloma, and solid malignancies, CS cervix, colonic carcinoma, prostatic carcinoma, and their miscellaneous, which are listed below. The treatment regimes we used in our patients were sofosbuvir, ribavirin, sofosbuvir, and decletacvir. Sofosbuvir, decletacvir, and ribavirin, and finally sofosbuvir and velpatasvir. SVR was checked in the number of patients. It is described here. In concomitant group, 2 patients died because of primary progressive disease, and 1 patient lost to follow-up. So SVR was checked in 31 out of 34 patients, while in the DA only group, 1 patient developed rash, and we have to stop the treatment, while 3 patients lost to follow-up, although they completed their treatment. But so SVR was checked in 50 out of 54 patients. As regards the SVR, it was achieved in 30 out of 31 patients in concomitant group. So 96.7% of patients achieved SVR in this group, while 96% of the patients achieved SVR in DA only group. The p-value was not significant as the number of patients in our study was very small. If we look at this slide, it's a bit a busy slide, but this slide shows a comparison of side effects experienced in concomitant group versus the DA only group. These side effects were comparable in concomitant as well as DA only group while they were receiving chemotherapy in the past. On the other hand, patient receiving only DA experience fewer side effects when they were given DA only alone. So this goes to show that the major side effects experienced were due to chemotherapy rather than direct acting antivirus drugs. In literature, Economides and colleagues reported SVR of 95% in cancer patients with concomitant chemotherapy and antiviral therapy. This study was published in 2016, and there were total patients were 20, and out of these, 21, and out of these, 20 patients achieved SVR. Another prospective observational study by Torres and colleagues showed overall SVR rate of 91%. Total number of patients was 141, and out of these 141, 27 patients were treated with concomitant chemotherapy, as in our study. So hence the SVR rate of 96.7% in our study is rather comparable, as well as even better results when treated with concomitant chemotherapy and DA only alone in cancer patients. Although our study is a unique study, but there were a few limitations as well. There is this sample size of our study was very small. It was retrospective in design and heterogeneous cancer population, and the majority of the patients were genotype 3. However, the range of cancer patients reflects the real life experience of treating HCV in cancer patients. In conclusion, our study suggests that DA therapies are safe and effective in HCV infected patients in various malignancies. They can concomitantly be used with chemotherapy to reduce the delay and interruption in cancer treatment. However, large prospective studies are needed to further evaluate the HCV treatment in specific cancer groups. Thank you.
Thank you very much, Dr. Saqib. Clinical based, very important study. I have just one question. Have you seen this therapy is more efficacious in certain type of chemotherapies or in certain type of tumors?
Actually, we did not have any very large number of patients, only 31 patients. So we can't actually compare in between. Although one thing we noted that those patients in which the R-CHOP was used, rituximab based therapies were used, they have one patient was that who actually did not achieve the SVR. So we can't actually comment because the number of patients of our study was very small. So we can't actually say certainly that whether it was due to rituximab or some other factor was involved.
Okay, thank you. So there is a question from Dr. Ahmed bin Hafiz. How can we link it with viral induced hepatocellular carcinoma? How can we link it with viral induced HCC?
So actually, I can't understand the question what they wanted to ask from us because our study was actually for the chemotherapy with antiviral
So
therapy.
he further asked, I think HCC patients should also be part of this study. Would you like to comment on this?
Actually, we had not, because we had not treated in our setup the patients with who had HCC, and we had not actually treated for HCV, as far as I know. So we can't comment on this, whether there was any benefit of treating those patients or not.
Okay, thank you very much, Dr. Saqib. So we'll move on to the next presenter, who is Mr. Rashid Bhatti from University of the Punjab. He will talk about in vitro determination of anti-cancer activity of medicinal plants against HEPG2 liver cancer cell line. Over to Dr. Rashid Bhatti. I hope this time he would be able to share his presentation with us.
Thank you, Dr. Saab. I am Dr. Rashid Bhatti, and I will present the in vitro determination of anti-cancer activity of medicinal plant against HEPG2 liver cancer cell line. Cancer is a major health problem both for developed and undeveloped countries, and it is the second major cause of death after cardiovascular disease. Liver cancer is the fourth major cause of cancer-related deaths, and its prevalence varies with respect to area. It is most commonly found in East, Southeast Asia, and Africa. According to the latest International Agency for Research on Cancer, liver cancer accounted for 4.7% new cancer cases and 8.2% of total deaths throughout the world. There are two types of liver cancer: primary liver cancer and secondary liver cancer. Primary liver cancer begins in the liver, whereas secondary liver cancer begins in the other body organ and spreads into the liver via metastasis. Primary liver cancer is more prevalent in developing countries and for the most part influences men. Hepatocellular carcinoma is most commonly found in adults, about 90% of cases. According to another study in 2018, age group of 45 to 60 years is affected with hepatocellular carcinoma. Major reason behind the high death rates of patients with hepatocellular carcinoma are late diagnosis, heterogeneous nature of hepatocellular carcinoma cells, and resistance against the chemotherapeutic treatment. There is a need for new treatments of hepatocellular carcinoma because present medications are less or not at all effective in eliminating cancer from the body. Treatment should not cause deterioration of liver function. Hepatocellular carcinoma is quite resistant to conventional therapies such as chemo and radiotherapies. Various health complications are associated with chemotherapy and radiotherapy. For example, pain, nausea, fatigue, diarrhea, vomiting, and hair loss. Available chemotherapeutic agents mostly show non-specificity for tissues, thus they are less efficient and also not safe. Moreover, targeted cancer monotherapy is rather expensive. Medicinal plants are considered a general health marker of a biological system. They have been utilized for the prevention and treatment of various diseases. Even today, medicinal plants are the basis of many medicines. All of the active components of medicinal plants have not.
Was our last presentation from Dr. Rashid Bhatti. So I think this is the first time this virtual format, and there were some problems by two speakers from outside of SKM, but excellent presentation from all presenters. So I would like to thank my co-moderator, Dr. and co-judge, Dr. Kashif Siddiq, and co-host, Dr. Akil. So here I would like to conclude this session. Thank you very much. We'll share the results day after tomorrow. Thank you very much for everybody and for all participants for their contribution and attendance. Thank you. Allah Hafiz.